You, all right. So I just didn't create a case-based kind of pattern here. Just quickly try to kind of run through this. And these are the advanced liver disease. To your previous question, like how do you make an assessment of a liver injury? Typically, the biopsy has been a gold standard, but as you know, it's an invasive procedure. It has a sampling variability issues when somebody puts a needle there. So it's a little bit tricky how you look at, what you're looking for kind of stuff. So these are the tools that are easily available with you in the routine labs called FIB4 score. You have apps, these just plug in those numbers and it spits out a number. That number will tell you the patient has an advanced fibrosis or not. Either it's from the NASH or hepatitis C, or the other scoring system called the APRI or AHD, LT, platelet ratio count kind of thing. Again, it has similar formula. There are also comparable performance levels of 76, 70, 72%, and you can make an estimation. So all these tests are pretty good in telling you that patient has cirrhosis for sure. You see what I'm saying? That is the easiest way that you can make an estimation in an office-based setting. Now, the other thing is we know the Child-Pugh score has stood the test of the time. We all know, I'm not going to go into details about checking for hepatic encephalopathy, ascites, albumin, PT, total bili, etc., how you make an estimation. But keep this in mind, when the score starts going beyond 10, 50% of death within 1 year is the estimated mortality. Now, MEL score, you all know about it, how to plug those complex information into the formula, into the complex formula, I'm sorry. And these are the mortality parameters, how the MEL score kind of stands. So anything less than 9, the mortality is like 2.9%. As the numbers creep up, the mortality rate is pretty high. This is 90-day, 3-month mortality or 90-day mortality, okay? And these are the other non-invasive markers to look at the liver disease kind of things. And I was talking about how do you make an estimation for liver disease. Surrogate markers are thrombocytopenia, okay, or pancytopenia, or even sometimes the AHD is more than ALT kind of picture at times. And obviously, you'll see signs of decompensated liver disease, ascites, all those kind of things. And on the CT scan, you tend to see splenomegaly. It's a very common thing that I come across quite a bit. Don't miss on these things. If you see somebody with a splenomegaly thrombocytopenia, always make sure you work them for underlying liver disease, whatever it is, the etiology would be. Or they may sometimes comment about the echogenicity. That's a very non-specific kind of things. The most common things are much more to look at the nodular liver, or hypertrophy or cardiac lobe of the liver, and portosystemic collaterals. Okay? There are new tools that are like evolving right now in the process. One of them is a FibroScan, which is a non-invasive methodology. It's just use that, it sends acoustic waves, ultrasound waves, and the higher the level of the FibroScan numbers, the advanced liver disease, and more also it's helping you to kind of manage portal hypertension too. If these numbers are more than 20, then they tend to have high risk for bleeding events, cancer risk, etc. And there's another kit on the block called a acoustic radiation force impulse. It's an ultrasound machine. It gives the exact same information like FibroScan. So there's kind of giving an idea about how the advanced disease is and what kind of complications we can expect from these particular findings. Okay, it's going to be the next generation of things, how to make an assessment for liver disease, and that's not out there for everybody's reach at this point, but most of these ultrasounds are there in the radiology department and they can make an estimation based on that. Now, portal hypertension, we all know by definition, the normal hepatic wedge pressure gradient less than 5 is normal. Anything above that starts going into the portal hypertension and formation of varus and everything. I'm assuming that you all know about the portal hypertension, where it's a gradient between the portal pressure and the inferior vena cava kind of thing. I'm sorry, this is all over the place, it got confused. But the difference between the portal pressures and the inferior vena cava, just like think about pulmonary capillary wedge pressure assessment kind of picture. And obviously, what does the portal hypertension manifest as is gastric and esophageal varices, ascites, SBP, HRS, pulmonary complications, and hepatic encephalopathy. Okay, just quick pathophysiology on this one. Remember this, Portal hypertension is a dynamic and a static thing. It all happens even in the liver and also outside too. So it's the sinusoidal endothelial cells, because of the cell contractility and everything kind of increases the pressures, that is causing increased hepatic resistance from that. And because of that resistance, nitric oxide is, not metabolized appropriately, and there is an increased splanchnic pooling happening in the splanchnic blood. And the more blood is coming, but the more resistance happening. So it's a complete bottleneck you're creating. That's what the portal hypertension is all about. Okay? If you understand that concept, then that'll make it a little bit easy when you're managing these patients. And that's where the beta blockade and all those kind of things comes into picture. So we all know about this one, esophageal varices, gastric varices, and the other things, very rarely portal hypertensive gastropathy, very, very rarely enteropathy and colopathy. These two events that I've never seen, but I've read it in the textbooks. And gastric vascular ectasia, which is not completely a portal hypertension manifestation, but it happens in a setting of liver disease. Obviously, we know how to manage the acute variceal bleeding kind of things. When somebody is in shock, try to use norepinephrine as their vasopressor support, and obviously try to use PRBC, and try not to over-transfuse them. Hemoglobin 7 to 8 is acceptable range. You try to push on them too much with these blood products that increase the portal pressures. The collapsed varices open up and cause more bleeding events. And obviously the medications are octreotide, IV antibiotics are standard. We all know about this one. And treat them with proton pump inhibitors if you're not sure which one is causing, because still peptic ulcer disease is the most common reason for bleeding events in people with cirrhotics. And obviously GI evaluation. And we all know about this one, how the varices can be looking at. These are very small varices. These are medium varices, no more F1, F2, I believe. And these are large varices with red veil signs. And these are the high risk for bleeding. And obviously, this is how you band them. And if you scope them after a week, that's a nasty picture you'll see. You never want to band them again. And you all know about the TIPS procedure. That's a salvage procedure. If you cannot manage with endoscopically, you go with the TIPS. Basically, what's happening is you're trying to create a shunt between the portal system and the hepatic system. You're decompressing the portal system. And you can use it as a first-line agent if the patient is you're not able to control the bleeding. Nothing wrong with that. But you need to have a good interventional radiology support to manage this. Post-bleeding instructions, approximately you try to continue the octreotide and antibiotics for 5 days. And at discharge, use non-selective beta blocker. Try to target the heart rate to less than 55, if possible, if the patient is asymptomatic. And if patient does not feel, obviously we talked about the side effects. And if patient discontinues the medication, risk of rebleeding is very high. Obviously, other modifying risk factors, what is driving the portal hypertension, especially alcoholism and etc. Questions on that?
So
yes? You can do that. Usually I try to do it. And the other good alternative is usually I use Coreg. Coreg is pretty good. If patient's insurance permits, Coreg is the best way to go. But I've switched him to propranolol too. And if it's not feasible or the patient is feeling symptomatic, just leave them on a metoprolol. There's nothing we can do about it. Just document it that, unfortunately, patient cannot tolerate it for whatever reason it is. Yes, sir. But keep that in mind that the beta blocker has failed in that patient if the patient is already taking metoprolol. You see what I'm saying? Either it's not optimized or whatever needs to be done. Yes, sir.
Patients, we did TIPS for them. There is a high risk for readmission for amniotic encephalopathy because they already bypassed the liver. They come in with high level of ammonia.
Right.
Is it reasonable to discharge them on bacteriolose prophylaxis at that point?
Yes. So it's an important point that you brought up. When somebody undergoes a TIPS placement for hepatic, the GI bleeding emergency kind of thing, give them lactulose to the point that you educate them. It's the most important thing is educating. Just giving lactulose, they may take your scheduled dosage, they may get diarrhea, they get dehydrated, they get encephalopathy. So it's not that you're kind of managing them, but they need to use that lactulose medication adjusting to their bowel habits. That's how we usually try to use that. And the incidence of hepatic encephalopathy is approximately 30 to 35%, if I'm not wrong, on a TIPS patient. So it's not that significantly high, but it's a good idea to send them on lactulose with educating them not to overuse it or underuse it kind of things. Does it make sense? Okay.
What if you couldn't form any ulcer on endoscopy? Is there any role of PPI?
There is no role for PPIs. Endoscopy ulcer you do not find. But you can use a double dose PPI therapy when somebody has a banding done, because they tend to have a high risk for rebleeding events because of the acid reflux. That's what they say. Now, that's a lot of controversy on that one, but it's okay to send them for at least it's a short-term treatment for them. You don't need to continue that PPI BID for a long period of time. Yes, sir.
At what stage of advanced liver disease or decompensated do you think that beta blockers should be relatively contraindicated? Because new studies are now showing that beta blockers should not be continued after a certain stage because they actually, what the renal syndrome and other like complications get.
Yeah, I usually keep it a rule of thumb of CTP score, anything more than 12, I try to stop the beta blockade, or they have an advanced MEL score like going to 20, 25 kind of stuff. That's what I try to do. But there's a lot of controversy on literature, which articles you're looking at and studies you're looking at it. Beta blockers proven to be effective, not effective, effective, not effective kind of stuff. That's back and forth kind of stuff. But as long as you document that the patient could not tolerate the beta blockade medications, just make sure you do a documentation. Or for these advanced like Charles-Pugh C going more than 10, that's why I stopped the beta blockade, then you're all covered kind of stuff. So usually I try to use a Charles-C, don't use the beta blockade, or MEL score more than 20 kind of stuff. That's when I stop it. So again, going back to the portal hypertension story. So we have the portal hypertension kicked in. More splanchnic vasodilatation is happening because of these more and more nitric oxide production in the splanchnic vasculature causing vasodilatation. That decreases the effective arterial volume. Once the pressures drop, what's happening is renin-angiotensin system is kicking. More vasopressin is produced in the system. That leads to more urine and sodium retention, free water retention is happening. That is also causing decreased pressures in the capillaries and then increased lymph formation. And nobody knows the tipping point when that pressures continue to progress and when they develop ascites kind of things. You cannot predict this is going to happen in 2 years, 3 years down the road. But this is the mechanism that is kind of evolving in the background. If you understand this one, then you can manage them where you intervene and kind of stop that process itself. Once the ascites kicks in, and then usually when somebody, we call it as hepatorenal syndrome, they need to have all these parameters going on, type 1, type 2, depending on what it is, or leading to SBP kind of stuff. Questions on that?
So can we stop using the beta blocker in MEL score it's already
2025, I try to use it depending upon what is the driving factor of the MEL score kind of things, as he was talking about. If they have an advance, that is the only driver. See, somebody has a chronic kidney disease from their underlying diabetes, and that drives the MEL score to 2025. Again, you're like kind of, that makes it a little bit skewy kind of thing. So that's why you should also take into consideration the Charles-Pugh class C more than C kind of things. You see what I'm saying?
just what is the disadvantage like because your concern was the hepatic syndrome.
So mainly it's for the hepatic. That's what I read in the studies. Like basically, it's a vasodilation. It's going to cause more complications of hepatic, renal, or basically this effective arterial volume is low and low as the liver disease advances, right? I mean, the beta blockers basically exaggerates or complicates more of that.
What they found is the study says the morbidity and mortality was very high on these people, independent of whatever it was. They've had a fall, so the pressures dropped, or they've been pushed pretty aggressively, or they couldn't tolerate it. Keep this in mind, beta blocker also causes a lot of depression, all those kind of things. So this was the issue using a non-selective beta blocker in a setting of advanced liver disease problem. There was multifactorial, it was not one thing. That's what happened when they looked at different studies. Some of them said they're beneficial, some of them said they turned out to be very ineffective kind of things. So it's tough for you to say where you stand with that and kind of stand in the test in between. You know what I'm saying? So it all depends upon clinical judgment, looking at the patient, what's going on kind of stuff. So if the blood pressure is too low, there's no point in pushing on them too much. You know what I'm saying? as it is, you could see there is most of the time how often the portal pressures are, you know, when guy has an advanced liver disease, blood pressure, their blood pressure medications have been stopped literally because inherently they are already having an effective decreased volume in the peripheral vasculature and the splanchnic pooling is happening, and you push on them, how far can you push on them? Does it make sense? Yes?
Recently, I had a patient, he had cirrhosis, came in with panisarca and encephalopathy, probably secondary to spontaneous bacterial peritonitis. His albumin was like 1. We gave him fluid challenge, almost 2 to 3 liters of fluid, but he did not have a lot of urine output with that. So I thought that, it's prudent to start him on some albumin, just to treat it as a hepatorenal syndrome. But I read a note from the nephrology saying that it can't qualify as hepatorenal syndrome because urine sodium is greater than 15. So in this scenario, the scenario that I just told, is it still prudent to give albumin in those cases?
So what I got the message from your question is there are 2 questions in this one. One is there is an SBP going on. Then there's a question of hepatorenal syndrome. So either way, still you can use an IV albumin to maintain the intravascular effective volume. What you're trying to do is though, try to keep that fluid within the intravasculature. That's what you're trying to do here and deliver it to the kidney. Why do you treat SBP so aggressively? Because they tend to go into hepatorenal syndrome, right? Because of cytokines released and causes vasodilatation and spilling all the nutrients kind of stuff. So you're trying to keep it by giving intravascular colloid kind of thing. That's the thing you're trying to manage it. So if you say SBP, you're still appropriate in giving IV albumin. That's actually a standard recommendation. If you have a kidney injury, you challenge with the fluids because the guy's albumin is so low, it's not going to respond to that. Then you need to use some IV albumin on them.
We don't need a diagnosis of hepatorenal syndrome in this scenario to give the patient albumin.
But you diagnose him with SBP, that's good enough.
Itself is an indication
Yeah.
to start albumin.
Because if the kidney injury did not happen, then how can you make a diagnosis of hepatitis?
They said that, as the patient has got multiple probabilities of acute kidney injury, it can be infection, sepsis that could be leading to acute kidney injury. They said that giving albumin is not a good idea.
Who said that?
They say, for diagnosis of hepatorenal syndrome, the input I got is that we have to exclude all other causes. Like the patient should not be in sepsis, the patient should not have dehydration. It's hard to differentiate because oftentimes all the pictures, they come together. See what I mean?
That's right. That's right. Yeah, no. We'll talk about it in a little bit. I know what your question, what you're trying to say, but usually the nephrologists use a different criteria, but the recommended guidelines are, you're right, you need to rule out infections, hypovolemic events, that kind of stuff. Urine sodium is not part of the criteria for hepatorenal syndrome. If you suspect somebody with a kidney injury, that helps to kind of make clinical diagnosis, but that's not part of the criteria. There's a difference there. You see what I'm saying? People use their clinical judgment based on those parameters, but it's not part of the criteria for you to diagnose HRS. So most of the time what I do is, I'm just like you, internist. I'm not doing anything sophisticated here. I'm trying to maintain the intravascular volume and see the kidney function improves or not. That's my goal, okay? If they don't improve, then I look for what are the kidney injury causing problems. Is it the urine sodium? Are there CAS? Are they spilling out protein? Is there any chronic kidney disease, known chronic kidney disease, or risk factors for that one? You rule those things out. Once you roll these things out, then you can probably say HRS. And sometimes clinically, no matter how much you do a thorough investigation, there's no way you can pin it down unless somebody gets a kidney biopsy, which I don't think it's easy thing to do in this kind of setting. So going to the ascites kind of picture, we talked about this. It's a very common thing. This is a common questions that are asked in the boards. The serum ascites albumin gradient, you all know about it, is actually 97% accurate in kind of saying patient has a portal hypertension or not, okay? So the SAG more than 1.1, if the acetic protein is less than 2.5, it's mostly dealing with the cirrhosis and late Budd-Chiari syndrome. If acetic protein is more than 2.5, it's mostly right heart failure, early Budd-Chiari syndrome, and veno-occlusive disease kind of picture. Obviously, the SAG is less than 1.1, then you're suspecting about acetic protein more than 2.5, normal sinusoidal pressure, and etiology could be tuberculosis, malignancy, chronic kidney disease, etc. If you understand this concept, that'll make it easy when somebody throws in a question at you, or come across cases where you manage them. Is that clear, or is there any confusion on this one, why this is happening? I want to kind of spend some time on this one before we move to the next slide. Why is the acetic protein less than 2.5 here? Why 2.5 more than here? What is? That is inherently, yeah. Synthetic function is compromised. What else is happening there? I should have put the slide down here. See, when cirrhosis happens, what's happening there? There's a significant amount of fibrosis that is all depositing along the sinusoids. The sinusoid fenestrae that are supposed to seep out the water is all compromised. So the protein is not spilling from the sinusoids being deposited with fibroblasts. Does that make sense? So neovascularization is happening in the sinusoids. So there's no protein spillage. So when you take the fluid out from the belly and you check for the peripheral, that's why the SAG is more than 1.1. And the protein cannot come out of this compromised sinusoid and fenestrae. Whereas in the kidney disease and malignancy and everything, your amount of protein that's secreting into the belly is the same thing what's in your serum. That's why the SAG is less than 1.1. If that concept is clear, it'll make things easy for you to think through that. Does it make sense? Okay.
Concept that is difficult to grasp is why the acidic fluid protein is greater than 2.5 in right heart failure and but cardiac, because thinking about it, it's technically cirrhosis again, right? Because
They don't have cirrhosis all the time. It's just a congestion happening there. Not all the time. The cirrhosis happens in a late stage on them. That's what it is basically. And the problem here is I could never find a proper information. A good question, why the total protein tend to stay in heart disease. It's very, very tough question. I searched and searched and didn't find an exact reasoning why you have that protein elevation in this kind of setting. But mostly the cirrhosis doesn't happen right away. Remember, the injury is not happening there immediately, but it's more like congestive hepatopathy kind of picture. Anything else? Okay, so we all know about this one. When you do this acidic fluid analysis, what to look for: gram staining, glucose, LDH, amylase and lipase, that's a plus and minus. You all know about the cell count, culture, albumin and total protein for us to see what's going on with that for checking for portal hypertension or infection, etc. And there's no point in check for anaerobic, TB cultures, because you have to kind of, there's a whole quantity of whatever the fluid was removed should be cultured out to kind of figure it out where we are with that. And cytologists, you have to spin out, get the cells out and do the cytology evaluation. And bilirubin and triglycerides are of limited value. And these things are not helpful on these people. Questions on that? So it goes back to the same question about how do you manage the ascites. So what you're trying to do is to break this mechanism, you're trying to use the spironolactone. Remember this, in ascitic management, spironolactone is very important, or aldactone, is very important for you to break that cycle. That's the most important diuretic that you have to use. Loop diuretics are like add-on to that to help to expel the excess fluid in your body. And I usually educate the patients to use the judgment based on their weight. They play around with the Lasix, how much they want to use. But key here is keep that in mind. Aldactone is very important part of that. And obviously your salt restriction, dietary management, etc. comes into picture. That's where this is working. Now the V2 receptor antagonists have been studied in CHF patients, but in cirrhotic patients they didn't do very well. So FDA has issued a black box warning on them. Still didn't stand the test of the time. Obviously if these things are not working, they are coming to the hospital, you try to maintain the intravascular volume by giving some albumin if they're not able to handle it. That's when you try to use the plasma expanders. Either you give albumin or sometimes they get FFPs for some other reason. It's still a plasma expander that does the trick. Things didn't work out. You go to the tips. And that didn't work out, you go for liver transplantation. Questions? For these ones, not for chronic liver disease, it doesn't help you. In alcoholic hepatitis, yes, but there's a lot of controversy on that one too. What it does is it doesn't change the overall mortality and morbidity, it just prevents hepatorenal syndrome because it's an anti-TNF agent. All right, so we talked about this weight management, close electrolyte monitoring, and obviously things don't work out, you go for the refractory or resistant to diuretics kind of picture. SBP, we talked about this, is it a what we did earlier on in terms of how do you diagnose them, but you need to differentiate, is it a spontaneous bacterial peritonitis or a secondary bacterial peritonitis depending upon what organism you have. It's a monomicrobial in SBP, it's a polymicrobial in secondary bacterial peritonitis. You tend not to see anaerobic organisms, total protein is more than 1.0, and the acetic fluid glucose can be less than 50, and LDH can be very high, and obviously the management is completely different on this secondary bacterial peritonitis because this is from the perforated viscous, that's why the labs are all over the place. Okay, that's how we differentiate it. Questions on that? Okay. These are the things. They tend to present with acute kidney injury, abdominal pain, fevers, and encephalopathy. You tend to give IV antibiotics, IV albumin. We talked about this one. When you say SBP, that's a standard recommendation, IV antibiotics, IV albumin. And usually try to kind of decrease the amount of albumin, how much you're giving, but usually what I try to do is put them on 25 grams every 8 hours for the next 3 to 4 days till things settle down. And there's a lot of controversy whether you have to repeat the paracentesis or not after day number 3 to see whether the patient's infection is resolving or not kind of stuff. People say do it, but it's a clinical judgment again. Questions on that? Obviously very important is keep this in mind. You can give an SBP prophylaxis if you have these parameters. One-time event, that's good enough. They need to be on the antibiotics for the rest of the life. If the total protein is less than 1.0 from the acetic fluid, serum creatinine more than 1.5, total bilirubin more than 3.0, or acute variceal bleeding. This is all prevention. Okay. So I just kept on repeating this. The main thing is you're coming to the hepatorenal syndrome next step when there should be a fluid and there's an ongoing progressive worsening of the liver disease leading to HRS. So basically, this is the Ascites Club criteria. They need to have cirrhosis plus ascites from portal hypertension relation. Serum creatinine should be more than 1.5, absence of shock, no improvement in creatinine in spite of volume expansion or removal of offending nephrotoxic agents, and absence of kidney function. How do you make the determination is checking for proteinuria, hematuria, renal cas, and abnormal renal ultrasound. This is the criteria proposed by the International Ascites Club. Now, people do check the urine sodium and all those kind of things as we're talking about. It's a clinical judgment of the nephrologist, but that's the diagnostic criteria. Okay? Yes? That's right. That's very important. That's what the whole thing is. It makes confusing. It's hard to say. So I usually never rely on that most of the time. My easiest thing is challenge him with IV fluids, give him some albumin and see how the kidney responds. The two ways you have to look at it. Their urine output also has to increase after you challenge them. Then it's not a pre-renal or dehydration kind of concept. That's when you have a clinical judgment, what's going on kind of stuff. Does it make sense? The creatinine may or may not budge, but if they say I'm putting out almost 1,000 ml from whatever the challenge you have done, it's not a hepatorenal syndrome. So typically what I try to do is volume expansion, IV hydration, rule out infections, no response. Then next thing is I try to go for volume expansion, octreotide and midodrine. That's the next step. Things didn't work out, whatever you did, then you add on these 3 combined agents and wait for a day or 2 and see how they respond by that time. Again, no improvement. Go for a volume expansion, continue the IV albumin all along and try to put them in a ICU and give him vasopressin protocol. Terlipressin is mentioned here. It's not FDA approved in the United States, but it's approved in Europe and other countries. Usually you tend to give it as a continuous infusion drip and does work. Usually it works after day number 3, but we have to wait and see what the FDA guidance will be on this one. But norepinephrine does the same job. And then things don't work out, then you're talking about renal replacement therapy based on if the patient is going for liver transplantation or not. See, what you're trying to do is doing a renal replacement therapy is to do a bridge therapy. Otherwise, it's an outcome is a futile event. There's no point in continuing the dialysis on these people for the rest of their life. Questions on that? Yes?
So is the first step to stop the diabetes and see
How they do, and give some, if the kidney function jumps up, you can give them some IV albumin or, fluids also most of the time. There's nothing wrong with that. Yes, sir?
Why would you reach for octreotide instead of just going straight for midodrine? Why do we still even use that in this situation versus just going for midodrine?
We use 3 of them together.
At the same time?
Same time. That's a triple regimen we try to use it. So what midodrine works more like peripheral vasoconstriction, and then octreotide works like a splanchnic vasoconstriction kind of thing. Okay. So you're trying to kind of work on it, double whammy kind of stuff. Okay. But you have to kind of adjust the midodrine also at the same time, continue to escalate it. So use it together. And then if that doesn't work, then I usually jump to putting in ICU, IV albumin. Make sure that the intravascular volume is pretty repleted. That's the key. But just giving normal fluids doesn't work. You need to give them some IV albumin or something like that and put them on vasopressin. All right. Almost, yes, sir.
How do you give albumin? Do you give 5% or do you want to give like 25%?
So I try to give it concentrated version, the 25%, the 100, it's 25 in 25 mLs itself. It's a very small volume and it does give the same benefit. Remember, the IV albumin half-life is 4 to 6 hours or something like that. So I try to give it every 8 hours. And if you give like 5% of it, it comes as a big bottle and you're kind of dumping that fluid also. So they become volume overloaded kind of picture. So try to give in concentration. If you want to give 5%, that's nothing wrong with that. Try to minimize the amount of normal fluid normal saline that you're injecting into them. And there's quite a bit of sodium involved in IV albumin too when they give it. So keep that in mind when you're giving these infusions. Look at the quantities, how much they're getting. Okay?
Could it suggest 1.5 gram per kg body weight of 25% albumin on day 1 and day 2?
That is for that's for the SBP, not for the hepatorenal syndrome. That's for the HSBP. Okay. That's the recommended guidelines, but usually I use the round the clock kind of things every 8 hours, quick infusion. So this is the difference between the hepatopulmonary syndrome and portopulmonary hypertension, which can be a chronic liver disease manifestation, and you tend to come across these patients quite a bit. So the difference between these two manifestations are hepatopulmonary syndrome is a vasodilation phenomenon with intrapulmonary shunting. Portopulmonary hypertension is vasoconstriction and remodeling. Okay? They can have a platypnea, orthodeoxia, and you check for ABG on them, PA2 can be 60, and they can have a clubbing in cyanosis. This is a common presentation is shortness of breath. When I took my internal medicine boards, I got 2 questions on these symptoms itself, on the platypnea and orthodeoxia. You know what that is, platypnea and orthodeoxia? When you change the position, the oxygen levels drop down. You see what I'm saying? Okay. And the way to diagnose is contrast echocardiography, okay, or technician macroaggregated albumin study. For portopulmonary hypertension, it's a right heart catheterization where you tend to see increased pulmonary vascular resistance and mean pulmonary artery pressures significantly elevated. Obviously, liver transplantation is a treatment for this one. You try to manage these people with vasodilator management, such as prostaglandins and phosphodiesterase inhibitors. And there's relative contraindication on this one too. You can consider liver transplantation if the patient responds to the medical intervention and the pressures drop to less than 35. Okay? Why is that? Can anybody answer? So what's happening in portopulmonary hypertension? There's intense vasoconstriction in the lung vasculature bed. So what happens when you do liver transplantation on them? Lot of splanchnic blood pooling is happening that dumps everything into the right heart. they're going to flash pulmonary edema and die on the table itself. So if they have a vasoconstriction in the bed and you're dumping a lot of fluid, where it's going to go? It's not going to go anywhere. So that's why you try to see if they are corrected or not with the pulmonary hypertension. All right? Okay. Hepatic hydrothorax, usually right-sided. Typically, they tend to have portal hypertension, small pores through the diaphragm associated with ascites, but can happen without ascites. Can consider tips too. Please do not allow chest tubes in these people. Keep that in mind. They tend not to do very well. They continue to drain, and it's going to be a headache on everybody's, whoever is managing this patient.
I think they fall off the transplant list if they have Pleurix catheters, etc.
Well, it all depends upon if they don't have an infection, that kind of stuff. You have to talk to the center specific kind of thing where they are with that. But typically, you tend not to do this by external drain placements. Because you're setting up for nidus for infections to come, and by the time they're listed and then they go to the transplant center, they may be infected. Who knows what's happening there? Everything, they're kind of, dumping the fluids, everything through that. And hepatic encephalopathy, we talked about this. What are the trigger factors? Is GI bleeding, inflammation that leads, with the infection, excess protein from their dietary indiscretion, dehydration, sedatives, excessive diuretic usage too. That leads to the hyponatremia, increased ammonia levels, and cytokine release, and astrocyte swelling, and obviously encephalopathy. All right, so try to see what's going on. And most of the time, this drives me crazy, is people talk about ammonia levels. Don't do ammonia levels. If you do it arterial ammonia levels. You cannot correlate a clinical finding on a patient with the level of ammonia. No studies have proven with that. So don't use ammonia levels. If you do it with the ABG and see how clinically it does. Every individual is different. So you cannot rely on this ammonia parameters at all. Treat the patient clinically. If you see an encephalopathy, treat them with encephalopathy, whatever it is. And treat the underlying cause. Did they have GI bleeding, infection? Avoid narcotics or sedatives if they got it. If they have a hypokalemia or hypomagnesemia, B12 or thiamine, etc., whatever it is. And obviously, you all know about this one, using lactulose, adjusting to their bowel movements, rifaximin, flagyl, if you don't have a choice, if the insurance is creating a trouble for rifaximin. Neomycin is a controversy. It can cause ototoxicity and nephrotoxicity. And there are other drugs in pipeline that have been looked into, is sodium benzoate, nonethine aspartate. Education is the most important thing for these people about how to use the medication, what to use and what not to use. Diets, medications, etc. Questions on that? That's it. Sorry guys, I had to breeze through that for the time constraints. Questions, concerns, comments, critique?
We often see patients with portal hypertension on a regular practice, and I read somewhere that guidelines suggest that they need to have yearly echocardiogram to rule out pulmonary hypertension. Is that done in regular practice?
No. I don't think nobody does it. I've never seen that. That's new for me. Probably it is, but we don't do it that commonly. We usually use echocardiogram when they are having any symptoms, or you're evaluating for liver transplantation if they're being considered for a referral or whatever it is. It's pretty unlikely. The incidence of pulmonary hypertension, portopulmonary hypertension, is very low in a setting of portal hypertension. So you don't need to do that quite often.
Is it underdiagnosed or is it?
Could be, but most of the time you get away with that. It's only when you are looking for transplant evaluation, that's when they get in. Most of the people walking with that elevated pressures without much symptoms, so you tend not to focus on that. And the other thing is vasodilator management is a little bit tricky. You need to have a special pulmonary hypertension expert to help you with that kind of stuff. You see what I'm saying? Anything else?